Hydrops fetalis. Hydrops fetalis is a Latin word. It means edema of the fetus. It is defined as a collection of a fluid in at least two serous compartments. It has two types, the immune and the non-immune, and the more common is the non-immune one. Non-immune hydrops is a heterogeneous disorder with a large number of possible causes and associations. Elucidation of the cause is of primary importance. Perinatal mortality rate is very much higher than the immune hydrops. It is between 50 and 98%. Etiology, it is very challenging to know the etiology of the immune hydrops. It has several causes, maybe cardiovascular, chromosomal abnormalities, thoracic compression, twin syndrome, some metabolic diseases, some infections like the torch infection, parvovirus B19, other malformations like chondrodysplasia, and some other malformations. Management is depends on the etiology, the gestational age, and the signs and symptoms. Maternal compromise such as preeclampsia or antenatal hemorrhage. Um, in these cases, we need to terminate the pregnancy regardless of the outcome. The non-immune hydrops is very complex subject, and its details is beyond the scope of a fifth or sixth year medical student. It's very specialized subject, so we don't need to know about it very much. Immune hydrops, it's caused by red cell alloimmunization, formation of antibodies for the red cell, the fetal red cell antigens. It leads to hemolysis and intrauterine fetal anemia. Diagnostic methods: maternal antibody determination by the indirect Coombs test, and we should have a titer for the amount of antibody in the maternal circulation. The level of the titer will determine how we follow up the pregnancy. Paternal homozygosity study, it can help us if the father of the pregnancy is homozygous. That means the baby will 100% be of positive blood group, so we can omit the third step of the diagnostic methods, which are the fetal blood typing. We can know it by non-invasive methods like the new technology of cell-free fetal DNA, and by some invasive methods like the chorionic villus samplings and the amniocentesis and the chordosynthesis. So if the paternal blood group is homozygous positive, we can omit the third step because all the outcome of pregnancies will be positive blood group. Following up the pregnancy, if the titer is below critical value, we just follow up the titer level every 4 weeks until 28 weeks, and every 2 weeks after 28 weeks. We follow with the ultrasound signs of hydrops. We will mention them in a minute. If the titer is above the critical value, we follow the pregnancy with MCA, PSV to detect fetal anemia, middle cerebral artery, peak systolic velocity, and then we do chordosynthesis of fetal blood sampling. Um, uh, the serous compartments that we can find fluid collection in them is the abdominal cavity, ascites, pericardial, pleural, and subcutaneous. Other signs is hepatomegaly, placentomegaly, aberrant Leica volume. We may have oligohydramnios and we may have polyhydramnios. These are pictures that represents the fetal hydrops, the pericardial effusion down on the write the ascites in the upper two pictures. Uh, as we said, if the father is homozygous, all pregnancies will be positive blood group, and if heterozygous, we have a chance of 25% to be negative. So in this case, we may benefit of knowing the fetal blood group. 15% of world population is Rh negative. Sensitization declining currently because of the antenatal and postpartum administration of Rh immunoglobulins. Why do cases still continue to occur? Because we have some maternal sensitization in the first 2 trimesters of pregnancies, and it could be silent. And because of this, we introduce the routine antenatal anti-D prophylaxis. Inadvertent omission of Rh immunoglobulins, missing the dose, inadequate dosing after pregnancy or after delivery. This could happen in cases of massive bleeding like abruption and placenta previa, in which the amount of fetal-maternal hemorrhage is high and the dose we give of the anti-D or the Rh immunoglobulins is not sufficient to destruct the fetal cells that crosses the maternal circulation. Low antenatal care attendance and low socioeconomic status. Um, we have some um, uh, antigens other than the D, which we have the immunoglobulin for, and these types we don't have immunoglobulins for them, like the C antibodies and like the kill antibodies. Pathogenesis, we have a considerable cell trafficking between the fetus and the maternal circulation because the interface is not an absolute barrier. If we have a fetal-maternal hemorrhage, uh, antigens can cross the placenta, stimulating the maternal immune system. B lymphocyte clones that recognize the foreign fetal red cell antigens is established, antibodies were produced, titers could be detected 5 to 16 weeks after the sensitizing event. In subsequent pregnancies, B lymphocytes will have the memory of foreign invasion by foreign fetal antigens. Upon second exposure, B lymphocytes will be transformed into plasma cells, which producing large amount of IgG, which can readily crosses the placenta, attaches to the fetal erythrocytes, sequestered by fetal spleen, leading to extravascular hemolysis and anemia. Anemia is the hallmark of red cell alloimmunization. It leads to enhanced hematopoiesis in the fetus, in the bone marrow and the liver. Cardiac output in the baby increases, and this is the concept behind which we can detect anemia during, using MCA-PSV. The circulation will become a hyperdynamic circulation, so the blood velocity in the fetal vessels will increase. Why hydrops fetalis happened? We have some mechanisms of decreased plasma colloid oncotic pressure, increased capillary permeability secondary to tissue hypoxia, increased free radicals, and impaired lymphatic drainage due to increased central venous pressure. Male fetuses are at 13-fold increase in the risk of hydrops and 3.4 fold increased risk of perinatal mortality. This is the middle cerebral artery using ultrasound to detect the increased blood velocity. This is another picture of real ultrasound. If the middle cerebral artery peak systolic velocity increased more than 1.5 multiples of median, the baby will have 100% risk of intrauterine fetal anemia. Um, in how we follow up the pregnancy with which is at risk of intrauterine fetal anemia and Rh isoimmunization. We follow it up according to the level of titer. If the titer is low, below a critical value, we just follow up the titer. If it is increased, we follow with MCA-PSV. If more than 1.5 multiples of median, we do chordocentesis and intrauterine blood transfusion. If the titer is already high, more than a critical value, we just follow up with MCA-PSV. Um, if um, if previously we have a hydropic baby or a pregnancy that was complicated by hydrops fetalis, the next pregnancy we should monitor it with MCA-PSV starting from 18 weeks without following the titer because the titer already will be high. Any baby that received intrauterine transfusion, it should be delivered at 35 weeks gestation after antenatal corticosteroids. Intrauterine transfusion, as we said, we do it if the MCA-PSV is more than 1.5 multiples of median. We take a blood sample from the baby, we send to the lab to know the baseline hemoglobin level or hematocrit level, and we transfuse the baby using the intravascular method, either in the umbilical cord, intrahepatic or intracardiac, or intraperitoneal. Um, uh, if the gestational age earlier than 22 weeks, we can't use the transfusion through the umbilical cord, so we use the intraperitoneal one. Complications of intrauterine transfusion, perinatal loss is 1.2 to 3.8%, fetal distress needing for emergent delivery is 5%, PPROM and chorioamnionitis. Neurodevelopmental impairment is 4.8%. Prevention of sensitization using O-negative universal donor during emergency of blood transfusion. We should give the Rh immunoglobulins or anti-D on the background of any sensitizing event like blunt abdominal trauma, early pregnancy complications, obstetric procedures, and we should give it routinely at 28 and 34 weeks gestation, or once at 28 to 30 weeks. So the routine anti-D antenatal or antenatal anti-D prophylaxis should be given to all negative group mothers regarding any case of sensitizing events. So in the presence of any sensitizing event, we should give the anti-D, and we should give it routinely to any pregnancy in which the mother group is negative, either 2 doses, 28 to 34 and 34 weeks, or just single dose at 30 weeks. After delivery of the baby, if the baby is confirmed to be a positive blood group, we should give him or her we should give the mother anti-D. These are the sensitizing events. Maternal complications of fetal hydrops, aberrant Leica volume, like polyhydramnios, it may lead to rupture of membrane, cordoprolapse after spontaneous rupture of membrane, postpartum hemorrhage, etc. Pregnancy-induced hypertension, postpartum hemorrhage, as we say, preterm labor because of polyhydramnios, birth trauma, gestational diabetes. Um, we may have a retained placenta or difficulty in delivery of placenta, putting the patient at risk of endometritis. Mirror syndrome is a very rare complication of fetal hydrops. Patients generally experience edema or pulmonary edema, and they may have hypertension and proteinuria. Mirror syndrome is a preeclampsia on top of hydropic baby. Um, as the fetal hydrops reverse the maternal symptoms well, and we may prevent early delivery by this process if we treat the intrauterine hydrops by giving intrauterine transfusion. The symptoms of preeclampsia will resolve. And thank you for your attention.